Hello, welcome back. The term surgical site infections refers to infection of the skin incision, but also include infection of the deeper anatomic tissues and organs where surgery was performed. Now, let's talk about etiology. Overall, Staphylococcus aureus is the most common surgical site infection pathogen, but other common pathogens include coagulous negative Staphylococcus, Enterococcus species, E. coli, Enterobacter species, and Pseudomonas aeruginosa. Methicillin-resistant Staphylococcus aureus, that is MRSA, is a serious surgical site infection because it is more virulent, difficult to treat, and associated with longer hospital stay, higher hospital costs, and increased mortality. Now, there are two scoring systems which we should know. These scoring systems are the Sepsis wound score and the Southampton wound score. The first one is the asepsis wound score. The mnemonic for asepsis wound score is asepsis itself. A stands for additional treatment, antibiotic for wound infection, drainage of pus under local anesthesia, debridement of wound under local anesthesia. S for serous discharge, E for arrhythmia, P for purulent exudate, S for separation of deep tissue, I for isolation of bacteria from the wound, and the last S stands for prolonged stay of patient in the hospital over 14 days as a result of wound infection. So this is the prognostic score which tells us about the wound infection. Now the next thing is Southampton wound grading system. In this system we will see grade and appearance of the wound. Grade 0 represent normal healing. Grade 1 represent normal healing with mild bruising or erythema. Grade 2 represents erythema plus other sign of inflammation. And grade 3 represent clear or hemoserous discharge. Whereas grade 4 represent pus discharge from the wound. And grade 5 represents deep or severe wound infection with or without tissue breakdown or hematoma requiring aspiration. Now, next point is what are the predisposing factors for surgical site infection? Many factors contribute to surgical site infection, including patient factors and various aspects of surgical management. So, patients factors are increased BMI, high ASA score, high NNIS score, diabetes mellitus, smoking, malnutrition, severe wound class, ascites, coexisting remote infection, staphylococcal colonization, and skin disease at surgical site, anemia, increased number of comorbidities. Now, some patient might have an asymptomatic UTI, that is urinary tract infection, and if you carry out surgery on them, then they can develop a surgical site infection secondary to that urinary tract infection. So we should get a urine routine examination before surgery. Next, the factor related to surgery and management. Duration of surgery, implantation of prosthesis, reoperation, longer hospital stay before surgery, and corticosteroid medications, inadequate sterilization and skin antisepsis, emergency procedure, hypothermia, and intraoperative blood transfusion, perioperative shaving, and failure to obliterate dead space. So these are the predisposing factors for wound infections. The next point we are going to talk about is the classification of surgical wounds. So first type of wounds are clean wounds or clean surgeries. The criteria are: first, no hollow viscus entered; second, primary wound closure; third, no inflammation; fourth, no break in aseptic techniques; fifth, elective procedure. Now, example of clean wounds are clean incised wounds like thyroid surgery, breast surgery, coronary artery bypass grafting, knee replacement, and uncomplicated hernia surgery. Now, in these clean cases, if we use antibiotic prophylaxis or if we don't use antibiotic prophylaxis, the risk of surgical site infection is same, that is 1 to 3%. So there is no role of prophylactic antibiotic in clean wounds except when we are placing an implant or a mesh. The next type of wound is a clean contaminated wound. So the criteria for the clean contaminated wound or clean contaminated surgeries are: first, hollow viscous entered but controlled. Second, no inflammation. Third, primary wound closure. Fourth, minor breaks in aseptic technique. Fifth, use of mechanical drain. And sixth, bowel preparation before surgery. The examples are elective or interval cholecystectomy, elective appendicectomy, urinary stone removal, LSCS, that is caesarean section. And the last is bowel surgery if the bowel is prepared. In clean contaminated surgeries, the risk of wound infection with the prophylactic antibiotic is just 3%, whereas without antibiotic it is 6 to 9%. So there is a definitive role of using prophylactic antibiotic in clean contaminated wounds or clean contaminated surgeries. The next type of wound is contaminated wounds. So the criteria for the contaminated wounds are: first, uncontrolled spillage from viscous; second, inflammation apparent; third, open and traumatic wound; fourth, major breaks in aseptic technique. And the examples are emergency cholecystectomy, emergency appendicectomy, and bowel surgery in an obstructed bowel. And if we use prophylactic antibiotic, the risk is 6%. If we don't use prophylactic antibiotic, the risk is as high as 20 to 25%. So in these patients, prophylactic antibiotic should be used. Plus, antibiotic should be continued in the post-operative period to reduce the risk of wound infection. Now, the last type of wound is dirty wound. The criteria for the dirty wounds are: first, untreated and uncontrolled spillage from viscous; second, pus in operative wound; third, open suppurative wound; and fourth, severe inflammation. All abscesses will classify as dirty wounds. Now, patients with peritonitis, fecal contamination will classify as dirty wounds, and any neglected traumatic wound more than 6 hours classifies as a dirty wound. That is why 6 hours is the golden period for traumatic wound. Now, the wound infection rate with antibiotic prophylaxis is 7 to 8%, but without antibiotic it is 30 to 40%. So in these patients, we use prophylactic antibiotic, and these antibiotics should be continued in the post-operative period as well. Now, what do you mean by the term decisive period for the wound? See, the decisive period for the wound is 4 hours, and this is the time required for bacterial colonization. That is why we give the prophylactic antibiotic before the start of surgery, so that the antibiotic concentration is at its peak and it remains at its peak for at least 4 hours, so that wound infection can be prevented. If you like the content, please subscribe the channel. Thank you.